Thank you very much, Brian, and thank you very much for Sami and all the organizers for inviting me to this meeting. It's very nice to see so many faces around here, some of which I recognize. And what I tried to do this morning is to look at this issue from a hematologist point of view. As Brian says, I'm sort of interesting background in that I've done a few things in my life, including being a trained hematologist, but also having an interest in fungal infection. Part of the problem with fungal infection, invasive fungal disease in particular, is the fact that the patients that have fungal infections are hematology patients. And hematologists in general don't know an awful lot about fungal infection. So I sort of stand in the middle there. So what I'll try and do in this session is to look at the issue of diagnostics from a hematologist point of view on the bedside and look at what has happened in the last 10 years or so. It's very interesting when you have Rosemary speaking before you. She has laid the ground rules, the grounds very nicely, so I don't have to do very much really. But if I were to start, I think, with an introduction, I don't think I need to convince a lot of people in this audience that fungal infection, invasive fungal disease. By the way, I would probably try and stick to invasive fungal disease as best as possible, because although we like to speak about invasive aspergillosis, quite often we don't know what is aspergillosis. And it would be, most of the talk would be invasive fungal disease, mainly mold disease, as a matter of fact. It's very difficult to diagnose, and many of the cases are diagnosed post-mortem. And sadly, the number of post-mortem that we're doing currently has been declining in the last many years, really. So it's very possible that we're missing quite a lot of the patients who might otherwise be diagnosed with fungal infection, if only we could diagnose them earlier. There are many surrogate markers that are available to help you with the diagnosis of invasive fungal disease, be it CT scan or other tests, and we'll come back to that in a minute. But the only thing that you can be sure of in terms of proving the diagnosis remains tissue diagnosis. And I suppose you could argue whether that's gold standard or not, given the difficulties in getting to that stage. Rosemary has alluded to this already, and you can divide the risk factors into two main categories, really, the acquired risk factors and the genetic risk factors. By far, the most important risk factor, as far as we're concerned, is actually neutropenia. The depth and the duration of neutropenia is perhaps the single most important risk factor for developing fungal infection. And to some extent, the functionalities of the neutrophils that you have is also important. So in some cases, some of your MDS patients may have not so low neutrophil counts, but the function of their neutrophil counts are very low. And there are other things that are also important, especially in the transplant setting, T-cell function and things that affect your T-cell function, such as CAMPA, anti-CD52, which impact on your fungal infection. Genetic risk factors, as mentioned, are becoming quite important, and I think by themselves, it's probably fair to say that they're not enough on their own, but they have to interact with the other acquired risk factors, really, to make sense. And I think that's why that last slide that Rosemary was sort of showing, risk profile in patients, I think at the very beginning, putting everything together would be a sensible way forward. So this is a broad sort of slide, sort of putting things in context. You can diagnose it if you're lucky with biopsy, tissue diagnosis, but majority of time that's not possible. So we're relying on either radiology, to some extent, morphological features that you can see on CT scanning, or PCR, or antigen detection, galactomannan and beta-D-glucan, and the lateral flow device as well. So from a clinician point of view, how do you see clinical diagnostics in invasive fungal disease? the way to look at that would be, the first issue would be your bedside sort of signs, as it were. And the other things are the things that you would want to add on to that to help you make a diagnosis. This is the essence of medicine, really. To get to this stage of diagnosis of fungal infection, you need a lot of specialties to get involved to help you to get to this stage. So diagnosing invasive fungal infection is actually a very multidisciplinary sort of approach. You need hematologists, obviously, whose patient they generally are. You need the nursing staff who obviously look after the patient and collect the samples most of the time, the microbiologist or mycologist and the lab to help you make the diagnosis. You need the radiologist, obviously, to look at the images, the histopathologist to look at the slides and the tissues that are provided by the surgeon and all the theater staff. And, bronchoalveolar lavage and bronchoscopy are important components of this test. And you need quite often a respiratory physician to help you with that. So it is a very multidisciplinary sort of diagnosis if you're ever going to get to that sort of stage. So on the bedside then, what has happened obviously as a clinician, the clinical judgment is still the key thing really for clinical medicine. I don't think you can take that away. We know the problem is not the most sensitive way of diagnosing fungal infection, but it remains the bedrock of medicine generally. And by and large, I think we still rely quite heavily on fever. How unwell or well is this patient who is immunocompromised and who is not responding to a usual treatment, usually a combination of antibiotics for 4 to 5 days. It's usually the first sort of thing that we still rely on, despite what I would say when we come to another slide or so. And you would then rely on some other issues, organ-specific sort of signs and symptoms that may help you. Do they have cough? Do they have pruritic chest pains, hemoptysis, and other things? Or if you suspect that they may have upper respiratory tract signs, sinusitis and things, those are important issues that we still rely on. And obviously, if they have space-occupying lesions, if you suspect fungal infections in the brain. If you take all that into consideration, then you ask yourself, can I make a diagnosis based on all this from the bedside? And quite often you can't, and you have to order some tests to be able to help you. Rosemary has already mentioned the EORTC criteria. So I would sort of summarize this very briefly. The first EORTC criteria, 2001, 2002, and rightly so. Before that, there was no diagnostic criteria, either for research or for clinical management at all. And so it was published in 2002, and is the first probabilistic model for diagnosing fungal infection. Probabilistic, and I think that's an important word, sort of tells you a lot about fungal infection. We're still working on the basis of probabilities rather than certainty, as a matter of fact. And the key things that really underpin this diagnosis is actually 3 things. The host factors that actually predispose the patient to fungal infection, the clinical manifestation that they may have, and the mycological results that would help you, that may be direct or indirect, to help you make the diagnosis. And fever for 4 days or more was classified as a host factor in 2002. And there were other issues, other things that were put into the 2002 EORTC criteria, your signs, major signs and minor signs, and you would see that probably that doesn't apply anymore on the current revised definitions. But the revised definitions, and obviously is in the process of being revised, remains probabilistic. We still are thinking of in probabilities rather than certainties, as it were. And obviously, we're now talking in terms of fungal disease as opposed to infection per se. And fever has been taken out of that current criteria, and the inclusion of beta-glucan, which was in there before. But in clinical practice, we are still relying on hematologists across the board, still rely to a large extent on fever-driven strategy to a large extent. And mainly, as I said, having temperatures for 4 to 5 days despite broad-spectrum antibiotics, and having no other lead, as a matter of fact, in a patient who is otherwise immunocompromised, and you can't find any alternative diagnosis for such a patient. And if you do it, then do a CT scanning, then if you see signs which are suggestive, then the question any hematologist would ask you, what more do I need to make a diagnosis of fungal infection? I'll say a few words about some of the tests that I've mentioned already, and the first one is radiology. And I'll probably just point to the fact, the bottom line, which sort of says, radiology still remains perhaps the single most important thing. And this is important that when we voted on this before, despite the fact that the majority of people in this room are microbiologists, all agree that radiology remains a key component of the diagnosis of fungal infection. And we know that there are, obviously, based on previous studies, clinical studies, and other studies, there are features which are very suggestive of fungal infection. Okay, so I would want to say a few things about high-resolution CT scanning, because we all speak about it. I'm not quite sure we all understand what we're talking about when we speak about high-resolution CT scanning. High-resolution CT scanning has been around for a long time, but I think it's fair to say that in the last 10 years or so, that's when actually this technique has been applied to help with the diagnosis of fungal infection per se. The original sort of high-resolution sort of CT scanning refers to a few things, and these are the three issues, three key components of that. The first thing is a very thin slide, so narrow collimation is an important component of that. And interspacing is also an important component of that, and that will become, I hope you can see clearly. One of the issues with when the classic high-resolution CT scanning is actually performed, and it was performed primarily for the diagnosis or investigation of interstitial lung disease, because what you want to do is actually sample the lungs rather than actually looking at the whole lung capacity, as it were. And in that case, all you're doing is actually making samples as you go along. In fungal infection, if you apply the same algorithm to what you would do for classic HRCT scanning, there's a possibility that you may be missing part of the lungs. And if, for instance, your nodule is present in between, you'll miss that. And it may be reported as being negative scanning, when in actual fact it's not negative scanning. It's just your technique which actually gave you this false result. Okay, so despite all the problems, I think we're now using HRCT and in a slightly different sort of way because of the presence of multi-detector machines that are available. You can rapidly scan the whole lung and do very quick reconstruction using very thin slides that allow you to sort of see in fine detail the morphology of the lung. Because it's a multi-detector sort of method, the chances are that you are not going to be missing out on the areas of the lung that may not have been scanned if you were using the classic HRCT sort of method. But you have to be very clear. I think some of you maybe when you go back, find out from your radiologist what sort of protocol they're using. whether if they're using the classic HRCT sort of approach where you have interspacing, or using volumetric sort of technique where you acquire the whole lung and then you reconstruct with that very fine thin slides. So I've mentioned this already, that some of the, there's no doubt that some of the things that we see on CT scanning correlate very highly with fungal infection, in particular invasive aspergillosis. So this is a pathological, radiopathological sort of correlation. 48 patients were looked into, so patients who had fungal infection and others who didn't have fungal infection. And halo sign obviously is highly significant there. And nodules and masses as well are significant. And the other ones are non-specific, and you can have in fungal infection and non-fungal infections as well. But there is a spectrum in invasive aspergillosis, invasive fungal disease, what you see on CT scanning. And there are sort of different morphological features you can see. So it's difficult sometimes for a radiologist necessarily to be absolutely certain other than describing what they actually have seen. But it's important to realize that what you see on CT scanning is morphology, and there's quite a spectrum into that. And the only way you'll be able to diagnose fungal infection for certainty is actually if you were to biopsy and find out which of these, but there's a whole spectrum of it. So this is the last slide on radiology. The downsides of radiology, as I said, is important, but there are important downsides. The first one is that it's subjective. You need someone to look at the images and make a judgment on what they think of what they are seeing. So if you have a very good radiologist who has an interest, in fungal infections, then the chances are they'll be able to pick up a lot more of the things. But even if you have a very good radiologist, the subjectivity is still going to be there. The study that we did in King's, and I'll describe it soon, shows that the agreement using the ERT sort of criteria, the signs, ERTC recognized signs, the agreement between two radiologists who are reviewing the images independently is quite good. But it's still possible to miss some cases in those sort of patients. So in fact, in our study, I think there were about 3 or 4 patients who otherwise would have been misclassified if you're using a single radiologist. And you're looking at morphology rather than histology, and radiology, as we're using currently, has not been sort of subjected to the same objective scrutiny as some of the other tests that are available, Galtaman and to some extent beta-D-glucan and PCR. The other thing I just wanted to mention is the biopsy. So biopsy, we said, is if you can get biopsy, that would be the way to diagnose fungal infection. Part of the problem is quite often you have quite small nodules which may not be accessible, and getting to the right place can sometimes be quite tricky. And one of the things we looked at was whether marking this with methylene blue would help you get to the nodules in question using video-assisted thoracoscopic surgical approaches, which is minimally invasive, and I think it's a useful sort of approach, but you still end up with significant non-specific inflammatory sort of signs, which may not necessarily help you rule out a fungal infection per se. So the positives for VATS approach would be that it's safe in a selected group of patients. The morbidity is quite low in a number of, if you select your patients very well, and you have a good pre-operative sort of support, making sure that the clotting is normal, the platelet support are given and all that. And it's very useful in that in some cases, some of the cases where radiologically they look like fungal infection, may turn out to be something else. So ruling out some of those would be useful if you have the availability of doing biopsy. But we know that it's not widely available. In a lot of centers, you may not be able to have the biopsy. It has a low negative predictive value. As I said, non-specific signs are fairly common. And I think the argument is that if you're using combined biomarkers, then you may be able to detect all the important moles you would otherwise find in a biopsy. So I think, those are the caveats for a biopsy. So I want you, this is the first question, and I'm moving into serology now, or antigen testing. And the first question is, do you use galactomannan routinely in diagnosing fungal infection? So if you can vote now, please. Okay, that's interesting. 51% are using it for when you suspect fungal infection. Okay, we move to the next question, please. Okay, so what is the turnaround time for in your center for galactomannan? Is it less than 3 working days, 3 to 7 working days, or more than a week? Please vote now. Okay, so that's quite interesting. I mean, 51% of you said you're using it to diagnose fungal infection rather than, and it's taking 3 to 7 working days in the majority of centers to get the results. And I think that's where the problem is. Because if you're going to use it for diagnosis, it has to be available, the turnaround time has to be reliable. And I think this is always the issue with the hematologists. If you want me to rely on the results to make a decision on a patient treatment, then that results need to be available to me in a reasonable fashion. I think 7 working days is not reasonable if you're going to rely on it for diagnosis. Let's move on, please. Okay, so this is another question on beta-D-glucan. And if you can vote now on whether you use beta-D-glucan in your practice, whether you use it routinely or for selected patients, if you can vote now, please. Okay, so 50% of patients, half of you, don't have any access to it at all. Interesting. 3%. Okay. So galactomannan and beta-D-glucan are accepted biomarkers for the current ERTC sort of criteria for diagnosing fungal infection. The question about how you use galactomannan testing is an interesting one, because obviously you can use it in a sort of surveillance sort of way, i.e. you have a program fashion and you monitor your patients as you go along, or you can use it for diagnosis. The problem with using it as a diagnostic tool is that we don't fully understand how galactomannan is released. And it's very likely that it's released intermittently, so at the time that you send your sample to the lab, it may very well be that you may miss it. And that's not to say that it's not released, but because that's how it is released. So I think probably if you're going to be using galactomannan, using it as a surveillance sort of method would be the way to go. We know there are issues with galactomannan and beta-D-glucan in that there are a number of false positives, especially with beta-D-glucan. And incorporation of these tests into clinical practice remains an issue. I think in clinical studies, number of papers, and, but in terms of incorporating this into clinical practice, that still remains an issue. And you can use blood or you can use BAL. Again, timely fashion is one that is important in terms of making the diagnosis. For instance, in our center, accessing bronchoscopy is not timely. They have at least 3 times a week, and it's dependent on when you can get a patient into this, so it's not very timely. And there are important cost issues as well. So although we may be saying we may be using, if we're using the full diagnostic approach, we may be saving on drug cost, but obviously we need to think about the cost of these tests as well. And availability are important issues. Very quickly, I just want to mention the study that we did in Kings, which is a prospective study. We recruited 203 patients, half of which were allograft patients, and a third were autograft patients, and they were followed up for about 4 months during that period. And what we wanted to see is actually using the current ERTC criteria, applying that into real clinical sort of setting, and seeing the applicability of those diagnostic criteria. And if you are relying, for instance, wholly on the basis of galactomannan and your CT scanning, the rate in our center was about 10% incidence of probable infection. And if you're using beta-D-glucan as the sole biomarker, then your incidence was about 16%. And it's only when you actually use the combination of the galactomannan and beta-D-glucan and everything else, then you get a much higher incidence of 21%, which I think majority of you would agree is a very high incidence indeed. So the combined, again, this has been alluded to by Rosemary before, is probably the way to go. I think that we want to be able to detect the broadest range of antigens as much as possible if we're not going to be able to get the tissue diagnosis. So combining actually makes a lot of sense. This slide is just pointing to the fact that sometimes it takes a long time, really, to diagnose fungal infection. So in some of the studies where they actually follow in patients for just 3 months, it's possible that you may miss your cases, especially the transplant patients, post-transplant complications. You need to follow them for a significant amount of time. So I think we're almost to the end. I suppose one of the key questions is that although we all talk about the different incidents of fungal infection in our centers, what is not quite clear to the majority of us is how many patients are we actually treating for fungal infection. So in our center, as I said, we had 21% incidence of fungal infection, but 50% of our patients, that cohort that we studied, had treatment with antifungal agents at some point. 41% were treated for more than 7 days, and 33% were treated for more than 2 weeks. That gives you patients who have been on antifungal treatment for 2 weeks, gives you an indication of the confidence of the clinician in terms of the sort of diagnosis, as it were. And that sort of mirrors what has been sort of reported in some of the postmortem data. So in conclusion, I think in the last 10 years, we've moved forward to some extent, but invasive fungal disease remains a challenge in clinical practice. Diagnosing this remains a challenge in clinical practice. And I think combination of biomarkers would be the way to go. And you could argue whether you want to use galactomannan and PCR, or galactomannan and beta-D-glucan, or galactomannan and other sort of combinations. But combination is really probably the way that we're going to go for it in the next 10 years, perhaps. And clinicians still depend on their clinical judgment, and I don't think that we can move away from that, and CT scanning would be a key component of that. Galactomannan and beta-D-glucan are hampered by the fact that in a large number of centers, they are not available in a large number of centers. And the performance of these tests may also be dependent to a large extent on the antifungal strategy that you may be using in your center. And clinicians need to be confident that the test works before they actually accept that as the way to make diagnosis. Thank you very much.